Hello, I am Dr. Annabelle Santos Volgman. I'm a professor of medicine at Rush University Medical Center, and I'm also the McMullan-Eybel Chair for Excellence in Clinical Cardiology and the medical director of the Rush Heart Center for Women. Today on Clot Chronicles, I will be discussing women in atrial fibrillation. My co-authors and I review the sex differences in atrial fibrillation, and I will summarize our findings in the next few slides. I will be using figures from my recent chapter and publications. This chapter on sex differences in atrial fibrillation was part of the book that was just released in February 2021 called Sex Differences in Cardiac Disease, that was edited by Dr. Nidhi Agarwal and Dr. Melissa Wood. This paper was a review about women in atrial fibrillation that we did for the American College of Cardiology Cardiovascular Disease in Women Committee and was published in December of 2020. The prevalence of atrial fibrillation in the United States is 5.2 million in 2010 and 12.1 million is estimated to have atrial fibrillation in 2030. But the prevalence of atrial fibrillation worldwide is much more, 37.6 million in 2017, with 17.8 million women and a little more men, 19.8 million men had atrial fibrillation in 2017 worldwide. Atrial fibrillation prevalence has been increasing in both sexes. However, on average, women live longer than men, so the number of women and men with atrial fibrillation are similar, despite the higher risk of atrial fibrillation in men. There are similar risk factors for AFib in women and men, but there are some sex differences. The risk factors that are similar in women and men are hypertension, advanced age, hyperthyroidism, alcohol intake, and cardiovascular disease. However, men have atrial fibrillation more than women when they have a prior MI, coronary artery disease, and elevated BMI or obesity. Women, however, have a higher risk of atrial fibrillation if they have diabetes, valvular heart disease, and elevated systolic blood pressure. There are definitely less women being enrolled in clinical trials. As you can see here, there are usually about 30 to 40% women in clinical trials for atrial fibrillation. These include the stroke prevention trials, such as these, and the rate rhythm trials, such as these, RACE and AFFIRM, were definitely predominantly men. And definitely the treatment trials, such as antiarrhythmic drugs and catheter ablation, are also predominantly men. This is a table of differences in prevention and the risk of stroke in men and women. Women are less likely to receive anticoagulation, but only in the United States. Global studies show that there are no sex differences in anticoagulation for stroke prevention and atrial fibrillation. In 2012, when warfarin was being used for stroke prevention more than the novel anticoagulants, women spent more time outside and below the therapeutic range of warfarin. This may be the reason why women have higher risk for stroke and more debilitating strokes. This is another publication, which is a nice outline of what we found that are unique characteristics of atrial fibrillation in women. So they have a higher risk of stroke, as I mentioned, and the embolic strokes are more severe and debilitating. Women are also treated more with cardiac glycosides like digoxin, and it's been found that these are associated with increased risk of breast cancer and mortality. Recent studies show that the glycoside concentration, digoxin concentration, should be less than 1.2 to decrease that mortality risk. Interestingly, because women are older, they are referred less often for catheter ablation. And some studies have shown that they have more procedural complications with catheter ablation, and they have higher recurrence rate after a catheter ablation. anticoagulation use for women for stroke prevention is less in the United States, but not globally. And they have a higher risk of strokes when not on the oral anticoagulants or warfarin. This is a left atrial appendage occluder, which we use when people have too much risk of bleeding and they cannot be on anticoagulants. And women have more device-related thrombotic complications from these device implantations. But they do have less bleeding when treated with these devices. We took a look at sex and racial and ethnic differences in atrial fibrillation and published it in the Journal of American College of Cardiology in 2019. It showed that women have less incidence of atrial fibrillation, and especially white women compared to white men have less lifetime risk and incidence of atrial fibrillation. But in Blacks, women and men have the same lifetime risk. There is a higher risk of death from atrial fibrillation in women and Black men and women. In the same category, women and Black men and women have more symptoms and poorer quality of life. So they have a longer duration of symptoms. They have more functional impairment and limitation of activities of daily living and worse quality of life scores. They also have a higher risk of atrial fibrillation, stroke risk. We found that women, Blacks, and Hispanics are less likely to receive anticoagulation in the United States, and that they have more rate control than rhythm control using drugs, cardioversions, and catheter ablations. So the key points I'd like to give are that women tend to live longer, so the lifetime incidence of atrial fibrillation is similar between the two sexes. Women with atrial fibrillation are older than men. This may be the reason why they have an increased risk of disabling stroke. So the older women are more likely to have other comorbidities, and they are less likely treated for rhythm control, and in the United States, get less anticoagulation therapy. Women tend to have longer duration of symptoms, have more atypical symptoms, experience more significant functional impairment, and report worse quality of life. And the last key point is that we need to get greater representation of women in clinical trials and future sex-specific research to improve the gaps in our understanding of the pathophysiologic differences, address disparities, and improve sex-specific therapeutic approaches. Thank you.